Well, good morning, good afternoon, and good evening, and welcome to this session. This is the country-led approaches on planning and operationalizing integration and mainstreaming of NTD programs. We're focusing on India and Ethiopia. I'm Dr. Eva Bazan, the Senior Associate Director for Implementation Research at the Health Campaign Effectiveness Coalition program. And I'll be joined by our moderator, Dr. Teshome Gebre, a Regional Director of the International Trachoma Initiative, also a member of our coalition. Next slide. So, of course, with thanks to our NNN sponsors. Next slide. So today, this is the agenda. We will be discussing decision factors and collaborative approaches being used by organizations in Ethiopia and India, and they are exploring the integration of NTDs with other health programs and planning mainstreaming with national health systems. We will also have time to discuss with you opportunities of how this may appear in your country context. And just to underscore, these projects are exploring the planning phase of integration or are in sort of early stages. So we'll have about 35 minutes of presentations, and we will come back to the different then there'll be breakout rooms at about 50 minutes past the hour, and where we'll get a chance to discuss with you some of your context and how this is relevant to what these organizations are doing. And then we'll come back to the main room here to debrief and have a brief share out. So yeah, just a brief overview. The Health Campaign Effectiveness Coalition program is hosted at the Task Force for Global Health in Decatur, Georgia, and we are funded by the Bill and Melinda Gates Foundation. We're in our second of third year, and we have a vision of country-led health systems using a strategic balance of targeted health campaigns in concert with regular health services to achieve and sustain health development goals for all people. And with our design team, and Dr. Teshome was a key member of that team, as well as representatives from other organizations, we developed a theory of change. And just to mention also that our program works with organizations in NTDs and also immunizations, polio, malaria, and vitamin A, sort of sharing. We want to foster dialogue and sharing insights across these areas. And our approaches are listed here on the slide, and also include support to implementation research to identify and eventually test and scale up effective health campaign practices and tools. So now I will turn it over to our moderator, Dr. Teshome Gebre.
Thanks very much, Eva, for that introduction. I believe everybody hears me very well. So you are here today, all of us, all of you that are in attendance. I must tell you that this is a very enlightening, a very exciting session. You will never be disappointed by being here this time. Could be morning or afternoon. I believe you will be excited. You'll be extremely benefited from this session. So without further ado, let me try to explain what campaign is, first of all. Campaign, for that matter, is time-bound, intermittent activities that address specific epidemiologies, expediently fill delivery gaps, or provide surge coverage for health interventions. So in general, this is what we mean by health campaign. You can find all what I am speaking, all what I am talking about now in the health campaign effectiveness website, as you can see it on the right-hand side of this slide. There's a technical brief in their website, so you can find all these definitions and explanations. So when we talk of health campaign integration, I think there are two ways of looking at it. One is full integration or co-delivery is coordination of most or all campaign components to provide two or more health interventions together at a point of service. And the other is partial integration, which is slightly different from full integration. It's a collaboration or sharing of specific campaign components between vertical health programs without co-delivery of interventions at the same point of service. So these are the two ways of integrating health campaigns. Next, please. So what do we mean by transition to primary health care? It's an approach to improve campaign effectiveness and sustainability by the transfer of ownership and operations of the independent delivery of health campaign interventions to the national primary health care service system. So when we intend or when we plan to transition to primary healthcare systems, what are our goals? What are we looking for? What are we going to achieve through that transition through that integration into the healthcare system? One is program effectiveness. Definitely program coverage and utilization will be improved. And number two, there will be high community acceptability of the primary healthcare system itself to receive a range of services. So it's kind of a supermarket approach to really get several services at a time. So it's cost effective and convenient for the community. And number three, it reduces community fatigue due to multiple campaigns. If we are doing several vertical campaigns, community will be so much tired of coming to multiple campaigns at different times. And the fourth advantage or goal of this transition or integration into health service is cost effectiveness. And the fourth one is sustainability of health outcomes. So these are the benefits of or the goals of transitioning into primary healthcare system from the currently practiced campaign mode. Next, please. So this is just by way of introduction for you, and today we'll be hearing presentations from at least 3 different groups. The first one would be Dr. Preta, and she's a professor and dean of research, and they have a project called Dastak, a knock on the door, a health behavior change communication campaign in Uttar Pradesh, India. That is the first session, which will be for about 10 minutes. And then we'll have other 2 speakers. So in total, we'll be having 3 speakers. I will be introducing the other speakers as we go along. Perhaps let me finish with the introduction. Okay, Fikre Seifa will be the second speaker. He's from Ethiopia. He is a national NTD program team leader, and he will be speaking on integrating NTD campaign integrations into the primary healthcare system in Ethiopia. It's an exploratory implementation research. The third speaker will be Dr. Zaude Brahanu. He is associate professor from University of Jimma in Ethiopia again, and he will be speaking on planned co-delivery of 2 MDS and other complementary health interventions in Jimma zone, community and health system readiness, opportunities and challenges. So we'll be listening to these 3 presentations, and each speaker will have about 10 minutes, and I will notify them if when they are 2 minutes away before completing the session, so that they can wrap up their presentations. So I call on Dr. Preta. Of course, I will be introducing these other groups of the breakout facilitators, perhaps later when we finish the presentations. Next, please. Dr. Preta, welcome. You are welcome.
Thank you. Thank you.
Dr. Preta, could you unmute, please? We can't hear you. Thank you.
Good morning, good afternoon, and good evening. I am Dr. Preta. I bring to you greetings from the International Institute of Health Management Research, New Delhi. We are discussing the findings, the preliminary findings of our project on integration of NTDs and other disease control campaigns in Uttar Pradesh, India. And this project is currently ongoing. Data collection is also ongoing. So the discussions today are the perspectives from the perspectives of the stakeholders of the district Gorakhpur in Uttar Pradesh. Next slide, please. Uttar Pradesh is situated in the northern part of India, one of the largest states of the country, the most populous state as well. And on the right-hand side, you can see that it is a large state, in fact, 75 districts, and our study area is located in the eastern part of Uttar Pradesh, Gorakhpur. Next slide, please. To give a context, Uttar Pradesh is endemic. Many of the districts of Uttar Pradesh is endemic to Japanese encephalitis, lymphatic filariasis, and other NTDs. And as we have already discussed many times in the past, multiple campaigns go on one after the other throughout the year in the district. So our research objectives would be to describe the ongoing NTD campaigns in the district, to identify the facilitators of integration of campaigns as perceived by the health functionaries, also to describe the challenges faced by the functionaries in conducting the integration. Next slide, please. So we have used a qualitative research methodologies, and in the study area in the district is Campier-Ganj block, the block named Campier-Ganj. And we had got state government approval for the study. The state had already written to the chief medical officer of the district, who is actually the lead of all the health related activities in the district. We had a meeting with the CMO, and CMO introduced us to his team in the district, and they selected the block for us on based on the district from the distance from the district headquarters, as well as the performance of the district in terms of campaigns. And we used the techniques of data collection that we used was focus group discussion and IDIs, in-depth interviews. At the district level, we did IDIs of the chief medical officer, the deputy chief medical officer for vector-borne diseases, the district program manager, as well as the assistant research officer. And at the block level, we interviewed the medical officer in charge, as well as the block program manager. And going down, we interviewed the ASHAs. ASHAs are actually link workers who are present at the village level between the community as well as a formal healthcare delivery system. In India, ASHAs and ANMs, or multi-purpose worker females, they are regarded as grassroots health workers. ASHAs are actually involved in the implementation of all the campaigns. They are the actual implementers, and ANMs are the supervisors for them. We did FGDs of the ASHAs as well as ANMs. We did one FGD of the community members as well. After taking an informed consent for the interview, for the recordings, as well as the video, any photography, we did IDIs and FGDs. All the FGDs and IDIs were audio recorded, and the language was Hindi, the local language Hindi, and they were transcribed first and then translated to English. We went through the transcripts, and based on themes of the objectives, which was the project description, facilitators, and challenges, we extracted the information. Next slide, please. The project is still ongoing, and we have engaged with government functionaries, international agencies, NGOs, as well as community leaders. We got tremendous help and support from all involved. We want to acknowledge the role of PATH, the organization PATH, who helped us in all the local arrangements, introduced us to the officials. They actually facilitated all the interviews, in addition to BMGF. Next slide, please. We faced a lot of challenges. The project, immediately after the project started, the second wave of COVID-19 broke out in India. Many of the project members were down with COVID. and also UP was also badly affected. We utilized that time quite well, I would think. Next slide, please. Now coming on to the key findings, there is already a surveillance campaign which is existing in Gorakhpur and the other study district we have, and it is called Dastak. Dastak means, it's a word in Hindi, it means a knock. So Ashas, the village level worker Asha, goes to each household. She caters to a population of 1,000 or 1,000 population or one village. She goes to each household and looks for fever. She knocks on the door and asks if there is a fever case. If there is a fever case, that case is referred to the block for management of fever. This program, this campaign was launched to manage Japanese encephalitis, which was a major problem. There were multiple outbreaks of Japanese encephalitis in Gorakhpur district and across UP as well. Gorakhpur was at the epicenter. And once the cases are referred to the block level, if there is need for intensive care, they are further referred. So this program has, according to the district and block functionaries, this program, which was launched in this campaign, which was launched in 2018, has helped tremendously in bringing down the cases of AES or acute encephalitis syndrome. There are also two other parallel ongoing campaigns for NTDs. One is mass drug administration for lymphatic filariasis, again carried out by the village worker, Ashas, who goes to each household and gives these it's a two-drug campaign, albendazole and diethyl carbamazepine. And for soil transmitted helminthiasis, the deworming campaign it also goes on as a separate campaign. Now, Dastak is the health department activity. This program for the campaign for Japanese encephalitis, it's actually part of a 11-department program, an intersectoral program to control non-communicable diseases. And this, in due course of time, has integrated other campaigns to it, including surveillance for tuberculosis, malaria, dengue, and now with COVID-19 outbreak, influenza-like illness as well. Ashas also use this opportunity to ask about waterlogging, sanitation, to provide information about all these as well. And Dastak, according to the Ashas and other health functionaries, it has the potential to include the other two NTD campaigns, which they carry out separately. Next slide, please. Next slide, please. So there is no problem with funding as per the information shared by them. And Ashas were widely praised by all the district and block officials. Technology has been increasingly being used in these campaigns, which has increased the efficiency of the program. It has also helped in communicating with Ashas quite quickly. It also helps in real-time supervision of the campaign when it is ongoing. And though there is a challenge that some of the senior Ashas are not very technology savvy, and so it requires more effort. However, these Ashas who have a tremendous big role to play in the success of these campaigns are overburdened as well, because they are also involved in other health programs, national health programs. And the Ashas were in fact of the opinion that since each campaign lasts for 15 days, they could, rather than having campaigns one after the other, they could do more campaigns instead of being involved in only one program. Next slide, please. There are many promising practices which have been shared with us by the district and block and village health functionaries. One was the involvement
Dr.
of the
Preta,
local.
You have 2 minutes to wrap up.
Okay, thank you. Was the involvement of local self-government and the civil society. The local self-government or Panchayati Raj institution, as it is called, has at the village level, it has village sarpanch or the village headman or headwoman. And involvement of that person increases the credibility of the program and also the acceptance of the program by the community. So as shared with us by a block functionary, we take Pradhan into confidence and they take the community into confidence. And then it becomes easier for the Anganwadi worker and ANM and Ashas to speak to the local population. Intersectoral coordination, the involvement of other departments is also a very good practice. Since the district magistrate or the head of the district is involved, other districts are also, there is no problem in involvement of other districts. All of us know how difficult intersectoral coordination is usually. Another promising practice is the chief medical officer and the medical officer at the block level offering themselves as role models. In full public eye, they consume these lymphatic filariasis drugs, MDA drugs. This has also helped in acceptance of the of this program. Earlier, it was seen that in earlier campaigns, the community used to think that this was a very strong medicine and they would throw away the drugs. And the ASHAs and the community members, the volunteers have been incentivized, which has been loaded. And lastly, the convergence with other programs, the platforms for other national health programs has been used as a platform for the NTD campaigns as well, which is actually a very good practice as described by our stakeholders. So that's all. Next slide, please. Thank you.
Thank you very much. Now I call upon Fikre Saife. Please hold your questions for the moment, and you will be. If you have any questions, you'll have the opportunity to discuss it in the breakout sessions. So, Fikre, please, you have the floor.
Thank you, Dr. Tashoma. Hello, everyone. Good morning, good afternoon, and good evening. My name is Fikra. I'm working in the Ministry of Health as NTD Program Manager. Today I'm here to deliver a very short presentation on integrating NTD campaign intervention into the primary healthcare system, which is an explanatory study design. Next slide. So this research project, as a background for this research project, as you may know, Ethiopia has the highest burden of NTDs from the sub-Saharan Africa. For example, the Ethiopia Trachoma program accounted 50% of the global burden, and the soil transmitted helminthes burden in Ethiopia accounts 34% from the sub-Saharan African countries. Of course, Podoconis is 25%, Leishmaniasis is 21%, accounted from the sub-Saharan African countries. The NTD interventions in Ethiopia is mainly dependent on external funding with a very limited integration to the general health system. As you know, the new WHO roadmap towards 2030 and the new Ethiopian Sustainability Action Plan framework highlighted or is advocating the need for program integration. But the problem is there is no adequate evidence on how to implement integration in the real world settings. Integration can be detrimental for the weak health system if the health system is not well prepared that can carry the NTD interventions. So that will impair the health system in general. So evidence needed for capacity and preconditions needed for integration. Those are gaps that we are going to discover by this project. Next slide. So what are the purposes and expected outcomes from this operational research? The purpose, the first one is to investigate the operational capacity of the Ethiopian healthcare system and support needed to transition the sustainability of integration into integrated NTD interventions. The second purpose is to identify acceptable and feasible strategies to either fully or partially integrate fully or partially to the primary healthcare system. What are the expected outcomes? And then operational capacity of the primary healthcare system to integrate the NTD interventions will be identified. Challenges and support is needed for the integration will be also identified. Systems and inputs of NTD interventions for either partial or full integration will be identified. Contribution of NTD program into the primary healthcare system will be identified. Feasible and acceptable strategies that can facilitate NTD integration will be also developed. Next slide. So what are the research questions that we are going to cover or investigate? We have basically two research questions. We have primary research question. What conditions and strategies facilitate partial or full integration of NTD interventions into the primary health care system? And as a secondary question, what are the challenges and opportunities of integrating NTD interventions into the primary health care system? Which systems or inputs of NTD interventions can be integrated into the primary health system fully or partially? And other one is how would integrating NTD interventions into the health system will impact the existing or the national, the primary healthcare system. Next slide. So the research design that we are going to employ is a mixed method explanatory implementation research. It has 4 distinct phases. The first one is a review of existing integration practices. So integration, the concept of integration is not new for the Ethiopian program. So we have already did some practices for the integration. So we will, as phase 1, we will review all those experiences. And phase 2 stakeholder consultative workshop will be, there will be a consultative workshop, and at phase 3, health system readiness assessment will be conducted from starting from national to district and sub-district level. And for the final phase will be phase 4, which is integrating strategy co-development. So for data collection, we will customize our data collection tool from different data collection tools. For example, primary healthcare performance initiative, consolidated framework for implementation research, or CFIR, readiness for change. We will customize our tool from those and others as well. Next slide. So this is our study area. Almost this is a big research project. We will involve about 7 big regions in Ethiopia. Apart from the 2 regions which are highlighted in yellow as here, Tigray and Benishangul, where there is an active insecurity in that region. So other regions will be part of this project. Next slide. So we will have different strata for data collection. The first one is national level. There will be a national level data collection. At national level, data will be collected from the NTD program, from working on the NTD program, from the primary healthcare unit, from the human resource and logistics and supply department in the Ministry of Health, and from different implementing partners and funders. So those are groups where the national level data will be collected. And coming to the regions and beyond, we have 5 stratas for the data collection. The first strata is regions. So we have 7 regions. Regions will be selected based on current security situation and the entity co-endemicity. So 7 regions will be selected. So strata 2 will be districts. We will have a total of 10 districts, 2 from the larger region and 1 from the remaining smaller regions will be. So district level data inventory will be taken from 20 experts who are working in the NTD program in the district level. And the strata 3 is primary healthcare facility level, will involve 30 primary healthcare facilities, 3 from each district, which means 3 from each district, and a total of primary healthcare inventory will be done from 60 primary healthcare workers. And the strata 4, that is a health post level. So the health posts, we will have a total of 90 health posts for strata 4. which means 3 from each primary healthcare unit. And the last strata will be at community level. We will involve a total of 90 community members for the strata 5 or community level data collection. Next slide. So what are the questions that we are going to ask for each K group? So we have national, regional, district level, program coordinators and decision makers. So the question we are going to ask to them is, how much willingness is there to fully integrate NTD control programs into the primary healthcare system? And how much capacity is there to avail NTD drug supplies through the primary health care system, including different NTD diagnostic kits and materials and so on. And the second group will be implementing partners and funders. So the question that will be addressed by them will be what kind of support are needed from the government and other stakeholders for successful integration of NTD interventions into the routine health care system. And the other group will be primary healthcare workers, people who are working at the primary healthcare level. How willing are you to expand your current role and take new tasks for NTD intervention? Is there a sufficient capacity in your primary healthcare level that can allow the integration of NTD interventions? And the most important group for our data collection is the health extension workers who are working in the health post. Do you think that the integrated delivery of MD campaigns through the routine healthcare service delivery is more advantageous than the campaign-based delivery? And we are going to ask them to explain more on this. Their opinion, what are the most outstanding challenges?
Please wrap up. Time is up.
Okay,
less
next
than
slide.
half an hour. Okay.
Next slide, please. So the research project will have, as I said, 4 phases. Already we have received the ethical approval, and second phase will be on October. So stakeholder consultative workshop will be conducted in October, and at third phase, there will be health system readiness assessment, and the last phase will be integration strategy for development. Next slide. So we have anticipated challenges. The first one is limited understanding and consciousness on what campaign integration into the primary healthcare system means, and a mitigation for this will be a consecutive consultative workshop, and there will be a huge amount of data collection, and qualitative data will be collected from a purposely selected subsequent subset of participants. And political instability, of course, we will rule out regions where there is an ongoing instability, and of course, the COVID-19 is also another challenge. So, all the necessary COVID prevention precautionary method will be applied. Next slide. So what are the successes from the project? We can see from the project perspective as well as from the national program perspective. Challenges and support needed for the integration will be identified from the project perspective. NTD interventions for the partial or full integration will be defined. Full range of contextually appropriate, feasible, and acceptable strategies that can facilitate integration will be designed. From the program perspective, yes, the Minister of Health and its development partners will test the research outcome in a small scale, and later on will be expanded for the national level. Next slide. I thank you.
Thank you very much, Fikre. I think you have taken more time than allotted. I think there is conflict of interest because I am part of the project. I'm sorry for that. And okay, before we jump into the next presentation, I would like to request all participants to register your interest. There are 3 breakout rooms in which you can choose to be assigned. One is the Indian project, which was presented earlier. And the second group is the EU Ethiopia, which Fikre right now presented. And the third would be the upcoming presentation from Jimma University. And I call upon Dr. Zaude to come in and give his presentation. Please try to keep to time as much as possible. Thank you.
Thank you, Mr. Moderator, Dr. Tashome. Hello, everyone. I'm Zaude Brown from Jimma University School of Public Health in Ethiopia. So I'm speaking on the behalf of my team on a topic entitled Planned Co-Delivery of two mass drug administration and other complementary health intervention in Jimma zone of Ethiopia, community and health system readiness, opportunities and challenges. Next, please. So I'm speaking on these specific topics. I will speak say a few things on background and rationale for this research, the research question and purpose as well, the implementation framework, and then finally we'll speak on the preliminary qualitative insight from the field. Next, please. So to begin with some background information, as already articulated in previous presentation, in Ethiopia, several health campaigns actually occur each year with inadequate coordination and communication at all levels. If you take especially the NTDs, there are a number of campaigns. In the region I am working, more than 5 campaigns are there, and we see some very little coordination among those different campaigns. That resulted in a number of challenges and difficulties. On top of that, even though health education and communication is actually part of the NTD program, we often see there is a weak integration of social and behavioral change communication intervention into campaigns. So on the top of that, as we all know, COVID-19 pandemic, disturbed actually the health system, including the MDS, a number of programs in Ethiopia, and this is also true perhaps all over the world. So little evidences exist on the integration of health campaigns as a solution as a potential solution to overcome these challenges. And so our aim is, next please. So our research aim is to address some 3 basic questions, research questions. The first one is to look at what is the effectiveness of full integration of 2 core MDA campaigns, specifically a deworming program for STH and chemotherapy for onchocerciasis, plus some complementary health intervention, namely WASH immunization. That means identifying some unimmunized or dropout children during our activities, then awareness creation and the promotion of self-protective behaviors on COVID. So we'll deliver all these things at the same time, the village level, then we'll see how effective it is. Secondly, we'll look at the generate evidence on implementation barriers and the facilitators. And thirdly, we'll generate more very valid evidence on how integration of tailored social and behavioral communication can impact the community CAP, knowledge, attitude, and practice related to the target disease. Next, please. So our implementation framework is we base actually on a well-known framework, which is REAM. R stands for reach, the effectiveness and efficacy, adoption, the implementation, then finally the maintenance. So throughout these ladders, we'll explore the barriers and the facilitators, which are which can affect positively or negatively the proposed or the planned integrations. Next, please. Our research design is an exploratory, sequential mixed design. That means we'll begin with exploratory activities, which includes consultative meetings with stakeholders, focus group discussions, expert discussions at different levels, Then followed by, we'll conduct a household level survey to document some of the community gaps. Then based on the evidence from this formative aspect, from formative part, we'll co-design the campaign, the micro planning process with key stakeholders. Then we'll go to the actual implementation, that means co-delivery of the proposed intervention at village level. Then at the end, we'll have the post-campaign survey, which integrates CAP study as well. Next, please. Our setting is, we just focus on some 5 districts in Jimma zone, which is co-endemic to both the ONCO and STH. And so we'll select some villages and in 5 districts to test and evaluate our interventions. Next, please. So as part of the formative activities, we are already, conducted a series of focus group discussion, key informal interviews, and discussion with experts from community level to the high levels at ministry level, including partners. So we already, have a large set of data, qualitative data at hand, and we are looking now at it, which are full of insights. Next, please. So on this slide, I will speak on some preliminary qualitative insights. Actually, this is not from the formal analysis. Rather, these are some of the insights from our observations while we are discussing with stakeholders, community groups, and from our field observations. So generally, what we learned is that stakeholders and the communities are very much supportive of the planned co-delivery. And it was perceived that it's technically feasible and acceptable from different angles. And we also learned that the system is ready for integrations and for adoption and maintenance of the approach. And one of the policymakers said that research which benefit to the program and the system is our priority, and that means that ready to adopt the proposed approach. So specifically, the planned co-delivery is perceived to be save time, logistics, and resources, improves the quality and efficiency at different levels, perceived to reduce burden from health workers, and gives more time for them to conduct to deliver routine services. More contributes to reporting and documentation quality. It's also perceived to increase community participation because there is a feeling of community fatigue, and that means communities are instead of coming again and again for different campaign. This gives more for community to respond to their expectation and demand in terms of getting more service at a time. Next, please. So you see here a very interesting quote from different stakeholders. Regarding the planned co-delivery, if you have to mention some of them, it's a great success to address 2 big campaigns at a time from regional policymaker. Integration of campaigns are sole option to improve the efficiency. Very interestingly, you see like 2 birds with 1 stone. This is from frontline health worker, very interesting. So there are so many interesting quotes, and how this shows how much they are very interested to or be part of the work. In terms of integrating the educational component, there is also high demand and very much valued. Like one of the health workers at district level said, education is a missile for combating NTDs. Very interesting. And that is, education is as equally important as a drug. That means how much an interest is there to integrate the social and the behavioral change communication in more systematic way to the NTD programs. Next, please. There are some, to be successful for the planned delivery, there are some necessary conditions for the co-delivery. Some of them are like having very strong community mobilization and education period to the program, aligning and synchronizing some of the formats, tools, capacity development, follow-up supervisions, and most importantly, issue of safety, how we can monitor it, side effects, There must be some clear stakeholder engagement and linkages, especially education, community, and health. Very important points. Again, there are so many opportunities. Yes.
Wrap up.
Thank you.
Please try to wrap up. Time is up.
Okay, thank you. So there are so many opportunities as well, and the Ethiopian health system have very strong community-based platform. That's really an opportunity, and many volunteers are there. Next, please. But there are some potential concerns that we have to really look at it, and some of them are very important, like safety issues, this decision on where the service must be delivered, and some of the interest from different stakeholders must be, carefully addressed. Next, please. So, generally, we'll expect to generate evidences on effectiveness, the implementation process, and finally, we hope we'll generate very useful lessons and practice for policy and guidance to the country and beyond. Okay, next. So with my acknowledgement to our partners and the stakeholders, so this is all about my presentation. Thank you so much.
Thank you very much, Dr. Zawadi, that excellent summary of your presentation. It's really very informative, and I see that some of the participants are struggling to or challenged with, assigning themselves to the groups. Some have been putting their choice in the chat box. So I'm requesting MYT, our organizers, if they can really help them in that process, or perhaps give additional guidance for the participants, for them to allocate themselves or assign themselves into the groups. So I know you will have lots of questions, comments, and so on. So we will be requesting you to go into the respective breakout rooms. And I would like to take a little bit of time now to introduce our breakout room facilitators. The room—
Dr. Tshome, sorry, shall I just bust in very quickly? Yes, everyone, if you're having trouble renaming yourself, if you look on the participants list and you find your name, you just need to add the number to your name. So you just click on your name, click rename, and just add the number. If you're really stuck, send us it in the chat and I'll get through it as quickly as I can. Thank you, Dr. Tshome. Sorry for interrupting.
No problem, Nick. That's really very helpful, because I can see everybody has been expressing their challenge. Okay, so room one, or breakout room one, facilitator will be Professor Sutapa, and she will be facilitating the DASTAC or a knock on the door, or health behavior change communication campaign in Uttar Pradesh. So that those of you interested in that group presentation, please go to assign yourselves to room number one. The second room facilitator will be Dr. Ismael Habtamu. He is assistant professor at the London School of Hygiene and Tropical Medicine in UK, and also adjunct assistant professor at Bahadar University. He will be facilitating the second room, and the topic, as you might recall, was presented by Fikre, integrating NTD campaign integrations in the primary healthcare system in Ethiopia, and exploratory implementation research. The third group will be facilitated by Professor Morankar Sudankar. He is a professor in health education and behavioral sciences from Jimma University. He will be facilitating the planned co-delivery of 2 MDAs and complementary health interventions, Jimma zone, which was right now presented by Dr. Brahanu, if I'm not wrong. So these are the 3 breakout rooms. So please try to assign yourselves into these rooms and enjoy the session. So we will be in these breakout sessions for for half an hour. Am I right, organizers? I think for half an hour.
That's
Is
correct.
that right?
That's correct, Dr.
Yes.
Shami.
Thank you very much, brother. So after half an hour, we'll get back here together in the plenary session, and then we will wrap up what really transpired in the 3 breakout sessions. That's all from me for now, and see you in the breakout sessions. So thank you very much. I think the breakout session was too short. It was very brief, I think, for exhaustive discussion. Perhaps I know time was really a big constraint, but we should try to make as much effective, as much as possible to make effective the time that we have now for this session. We have about, I think, 10 minutes now to wrap up. So let me ask group 1 to give us their highlights of their discussion. Dr. Sutapa and Alison. Ellie?
Yes, thank you. I believe I'll share our MIRO board very briefly to walk you through some of the highlights from our discussion. So hopefully you all can see this. I'll zoom in. So first, we really had 3 points of our discussion, and they roughly followed these overarching questions around how we select diseases for integration, or kind of how we first start to formulate the approach and make determinations. And really what we focused on here was the point that any consideration must be first grounded in the community needs and community centered, involving persons affected, and really first understanding the status of various diseases within the community. And we really didn't progress from there, but we all acknowledged that was kind of a key starting point. Again, as we talked about the feasibility of integrating campaigns, the focus on community and involving health workers in India, the ASHAs, as Dr. Preta mentioned in her presentation, or community health workers, community member volunteers that are involved in health campaigns. And involving block level officials or local officials in the pre-planning. We talked about measures of success, and really just starting this theoretical conversation around coverage versus cost effectiveness. They don't necessarily have to be opposed, but just the considerations there. And finally, we were able to determine, or to highlight, the importance of considering hard to reach populations, which is again involved in this coverage, and frankly, cost effectiveness considerations. And finally, there was a mention of the necessity to ensure that health workers are appropriately trained to manage and distribute integrated campaigns. Thank you.
Thank you very much, Ellie and Group 1. Do you have anything to add, Dr. Sutapa? Or is that welcome?
No, I think she has captured it quite well. So it's all from, okay. Thank you from my side.
Thank you. In the interest of time, I also appreciate. So Dr. Ismael and is it Anupama? I think 2 of you, go ahead, please.
Thank you, Dr. Teshoma. Yeah, we had also a really excellent discussion with our group members. Lots of important points have been raised. So we had really 3 important questions that we'd like to get feedback on, but we didn't have enough time really to go to the 3rd one, but we have discussed 2 of them. So the first one was asking on what does an NTD campaign mainstreaming into the routine healthcare system mean, particularly in the context of where people are operating or their organizations are operating. So I think the important point was the importance of the presence of lots of ideas, actually, lots of overlapping ideas and definitions about mainstreaming and integrations. But there is also some consensus common consensus on a spectrum of shared responsibilities between implementers and NGOs and Ministry of Health. So the issue basically we have got is actually transitioning and mainstreaming probably may be similar, but integration can have a slightly different meaning. The other important point was when you talk about mainstreaming, the end goal is probably, the total end goal probably need to be a total ownership by the national health system. That is again thinking about transferring responsibility to the government to run the NTD campaign interventions. The other one is mainstreaming is also an active process, an ongoing process when you think about mainstreaming, and that the Ethiopian system has lots of expertise and capacity to do that, mainly in managing lymphedema for podocyniasis, so that we can really use the system, but also need to be careful not overburdening our cadres, such as the health extension workers. Next, please.
Thank you. Ismael, I'm going to cut you off because time is too.
Yeah. No worries. Yeah.
Okay. Sorry about that. So we have to move to the next session, group 3. Who is presenting? Please go ahead as quickly as possible. You have 2 minutes. Hello.
Sorry, my apologies.
Hello.
I had some technical difficulties with MIRO when I was taking notes, so I'm not sure I captured everything. Dr. Murankar, would you like to?
Okay, I would take
Dr. Murankar. Okay, go ahead, please.
Yeah. So basically, there was a discussion regarding during the discussion, mainly it had brought out 2 major things on the challenges. One is on the social and behavioral change communication, how the behavioral change will be measured, as well as what is expected for the behavioral change when the co-delivery is happening, and how you are going to measure the SBCC. Another challenge has come out from the, it was a experience sharing from the Nigeria, and they brought out that integrating 2 ministries, it is a political problem, like a health ministry and education ministry for the school programs and the house-to-house campaigns for the community-based this thing. So those are the very important challenges they brought out, even their experiences, and then how the this project will, or the people will take consideration into those things. So we have a very good discussions about the 2 important discussions, these things, about the integration, actual implementation, and the social and behavioral change, a theoretical part of the co-delivery, behavioral change communication, and measurements. So I think I wrap up here, and then there will be discussions if it. Okay.
Thank you very much, Dr. Murankar. That's really very, very helpful. And I'm very sorry. This is really a very short time. This is a new concept. And this shift in strategy is just a new one for most of us. So it's very difficult to really come up with something in this short span of time. So I'm very sorry for cutting you short in your presentations, because we have only now 1 minute left before we wrap up. Eva, do you have anything to maybe summarize and or make last minute announcement? I don't know.
Sure. I just want to say that there are opportunities to engage with the Health Campaign Effectiveness Coalition program. We have a meeting coming up in October, our annual meeting, and we will address issues of integration and mainstreaming and engage. So please register if you can. We'd love to hear from you. It's our 2nd annual meeting. We've developed over the past year, along with our campaign integration working group, a toolkit for decision to help countries decide when and where to pursue campaign integration. It's very much a beta early version, and so we do welcome your feedback, and it's right there on our website. And we hope your insights from this session today will help us also evolve that and combine that with other guidance coming out from the World Health Organization and your organizations. And just to say, we featured some of our awardees today. There'll be some other short-term awards that are ending this month. that will address the potential for integration of NTDs and some other health interventions, these coming out of India, Nepal, Colombia, working with remote populations in the Amazon, and looking at some past actual integrated campaigns, polio and vitamin A in Ghana, some others from Nigeria and Guinea as well, those related to immunization, but they may have some lessons for NTDs as well. So we are happy to share information on these projects and look forward to engaging with you in further meetings. And thank you for coming, and I'll turn it over to Dr. Teshome for last words.
Right, thank you very much, Eva. This is also a very important piece for us, and I'm really very much grateful to everyone who have really joined us. We had, at least until this moment, we have about close to 50 participants. So this is really great. And at the end, at the beginning, we had more than 69 or 70 participants. So this is a great success, but time was the big challenge, and as it is the case always in these kinds of platforms. And therefore, we are really very sorry for not giving enough time for everyone to really express their views. But as Eva said, we'll have opportunities in October as well. So I thank you very much and see you in October. Thanks.